Kedar Roplekar. I am cardiologist at Roplekar Healthcare Center, Aurangabad. Today I am going to speak on latest update in hypertension. As per WHO, nearly 63% of total deaths in India are due to non-communicable diseases, of which 27% are attributed to cardiovascular disease, which affects 45% of people in 40 to 70 age group. Raised blood pressure is among the most important risk factors for cardiovascular diseases. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and poor follow-up. In India, the prevalence has also gone up over 30 years, 38% in men and 32% in women, from 29% and 28% respectively, according to WHO. Despite that, nearly half of people, or 57% of men and 41% of women with hypertension, were unaware of the condition. Additionally, over 62% of the men and more than 53% of women living with hypertension did not get treatment. Medication was used to control blood pressure in fewer than 1 in 5 men and 1 in 4 women with hypertension worldwide. The International Society of Hypertension has released 2020 Global Hypertension Practice Guidelines. The inclusion of optimal and essential treatment paradigms attempts to address the issue that in resource-poor settings, optimal care refers to evidence-based standard of care, and whereas essential standards refer to minimum standards of care to allow specification of essential standards of care for low resource settings. The ACC-AHA has released a scientific statement in 2021 offering new guidance for management of stage 1 hypertension among patients with low ASCVD risk. Among low risk adults, that is, no ASCVD risk or 10-year ASCVD risk less than 10% with stage 1 hypertension, that is blood pressure between 30 to 139 systolic and 80 to 90 diastolic. Management starts with non-pharmacologic therapy. If blood pressure remains uncontrolled at 3 to 6 months, consider starting pharmacologic therapy. Acute respiratory distress syndrome is a potentially fatal condition involving lung damage, and experts often associated it with severe COVID-19. A recent study which appears in the Journal of American College of Cardiology reports that metoprolol can reduce lung inflammation and improve respiratory function in people with COVID-19 induced ARDS. Lowering systolic blood pressure targets down to 110 to less than 130 range substantially reduced cardiovascular adverse events in the STEP randomized trial, affirming the sprint findings for an older Chinese population. Among some 8,500 patients aged 60 to 80 in China, the intensive target trimmed 26% of the composite cardiovascular risk. Findings from now a second major trial which support lower target could unite the guidelines, which even among US professional societies range from thresholds of 130 to 150. With regard to prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2018 European guidelines on the management of arterial hypertension recommend that the diagnosis of hypertension should not only be dependent on office blood pressure measurements, but also on out-of-office measurements, such as ambulatory blood pressure monitoring or home blood pressure monitoring. 24 hours and nighttime blood pressure measurements were associated with greater risk of mortality and composite CV outcome. Thus, they may be considered as the most relevant measurements for estimating CV risk. For every 20 by 10 millimeters of mercury increment of blood pressure measured at night, the risk of mortality increased by 23% and the risk of cardiovascular events by 36%. Most patients with hypertension required lifelong medical therapy to achieve optimal blood pressure control. The 2018 European guidelines equally recommend 5 classes of antihypertensive drugs. Considering high non-adherence treatment, the importance of combination treatment is particularly highlighted to improve adherence to therapy and blood pressure control. Therefore, the 2018 European guidelines recommend, especially in the context of lower blood pressure targets, to start antihypertensive therapy than initial dual fixed dose combination of ACE inhibitor or ARB with calcium channel blocker or diuretic. Since July 2018, products containing valsartan have been recalled worldwide. The reason is the detection of a known carcinogen, namely NDMA, N-nitrosodimethylamine, which can be found in candesartan, irbesartan, losartan, olmesartan, and valsartan. NDMA has been classified by WHO, International Agency for Research on Cancer, to be carcinogenic in humans. If 1 lakh patients would have received NDMA contaminated valsartan from Zhengzhang, Yuhai for every day for 6 years in the highest dose, it could result in 22 additional liver cancers over the lifetime of these patients. This is a manufacturing site where highest levels of contaminants were found. The presence of NDMA in these drugs could lead to 8 additional cancer cases in 1 lakh patients if they had taken the highest daily dose over 4 years. Valsartan recall accompanied by a significant increase in the rate of emergency departments visits of more than 6%. The HYGEA study represents the largest study that tested nighttime antihypertensive treatment. In this trial, chronotherapy was associated with a significant reduction in endpoints, including death. The HYGEA chronotherapy trial tested whether nighttime therapy in comparison to usual upon awakening hypertension therapy exerts a favorable CV risk reduction. The largest study included a total of 19,084 hypertensive patients. During an average follow-up of 6.3 years, 17,052 patients experienced the primary CV outcome. An ambulatory blood pressure measurement was performed for 48 hours to collect data on how blood pressure differed during sleep. The relative risk reduction for CV events was significantly improved for nighttime treatment when compared with awakening treatment.